Joanne, thanks so much for joining us. I know it's been crazy out there. As our audience will learn soon, you've been on the front lines with this whole COVID craziness. You're a mom, you're a radiation therapist, you're running a business, and you're doing all kinds of original research into genetics. And that was the main reason we wanted to get you over here. But everyone's so curious about what's going on with COVID right now. Can you tell me a little bit about what you're doing with your business? I know you just repurposed your business for COVID testing. Is that correct?
That is, and it's been just a crazy several months. Interestingly, my background, my PhD was in a virus lab, but all the research, as you mentioned, is really in genetics. And, I started this genetics company about 10 years ago, MiraDx, and we have an affiliated nonprofit, MiraKind. And everyone that knows me and knows what that's about is much of it is just try to help and try to improve, people's lives.
How did you, you're, and we'll get into that, but you're doing all kinds of diagnostic testing for genetics and everything. And I remember calling you up to get some diagnostic testing and said, sorry, Mark, we are jumping with both feet into doing COVID testing. And this is diagnostic testing, right? This is the holy grail. We wanted to find out who has the COVID, who doesn't have it. And now you're going full blast at that?
We are. So, we realized that we had both kind of the skill set, the lab certification, and the knowledge to really pivot. It's just not that different. Our genetics, we take a sample and take out DNA, which is the genetic material. For COVID, you get a sample, you take out RNA, much the same technology. And to see it, then you have to look at it by doing all types of steps and magic amplification so that you can measure these differences. Same idea that you measure COVID in a sample.
So you knew you had the professional expertise to do it. What made you think that is this like an opportunity, or is this someone approached you and said we need help, or how did you make that transition?
It truly 100% was my lab lead and I sitting across from each other and saying we really need to try to help. And I really thought it was going to be a sprint. But we said, all right, and if we're going to do it, we're going to do it right. Running 100 tests a day is not enough. We're going to look at the different ways you can do it, troubleshoot it. I've never thought quite so hard to set it up. We had a lot of the basic equipment, but we wanted to, that RNA isolation step's very complicated and labor intensive. So we invested in some machines that could do it, which they'll work for our genetics research as well. And we just started. It was about March 15th. And we started investigating and trying different kits and testing different methods of collection. We were up and running by April 9th. Wow. We started our first test. And from the beginning, we could run about 2,000 tests a day, which we quickly surpassed many big institutions in what their total testing that they'd done. And I was proud of that. And, we worked hard, but, it was like building the plane while flying it, just as far as building up support and staff.
Are you continuing to expand?
We are. So, that was the first wave. And the second week in June, a different group took over the county. We became one of the main testing sites for the county. We're testing about 3,000 people a day through those drive-through clinics.
Wow.
They started, what's the word? They started winding that down. And so there was a week or two in June that I thought life was getting normal again. And I started, working to get DNA out of these RNA samples and was really excited and starting to write up some of our findings, which are really interesting. And then all of a sudden, the whole next wave came, and we're much busier than ever.
So this is going to go for a while, is what you're saying. Are there aspects that sounds like you've been transformed into a COVID expert? You've been, we'll go into what your expertise I knew you for in the prostate cancer world and all this, but. Are there some interesting things that you've learned about the COVID craziness?
So interesting, and I'm just dying to share that knowledge. That's kind of what we try to do at the company. So what we realized from the beginning, some important things, I think, for why COVID's so widespread. One, there's a lot of asymptomatic people, just people that have no symptoms that are out there, you and me, feeling fine, looking fine. Who will never feel symptoms but have really very high levels of virus.
Wow.
So that's much more common, and we're about to take a closer look at that, but it's not uncommon, and we picked that up from the beginning. There has been no population we've tested over 50 people that has not had a positive person.
Wow.
And they do not feel sick. I mean, they're not there with fevers, right? They're going to work.
So you're just picking them up in the course of mass testing?
Yeah, these group testing for screening at sometimes nursing homes, and it's a mild infection for them, but they may interact with someone where it's a very serious infection.
Right.
And they're contagious. They're expressing virus. The second reason, so that's one reason I think that it has become so widespread. It isn't that people are being negligent. They actually don't know they're sick and contagious. Another thing we picked up right at the beginning is that people do continue to shed virus for months sometimes.
Wow, even after they feel well.
Yeah, the current guidelines are 10 days after your first symptom. If you are 3 days without a fever, you are free to go mingle.
Back into the
world, into the mainstream. You know, we have our first cohort, it's 25,000 people, and about 800 had repeat testing. And we find for the repeat testers, half of them are still positive at 23 days. So that's...
Wow. So that means that we're going to be dealing with this on an ongoing basis. I mean, that sounds almost, how these people would have to be isolated for several months.
I know. And, you know, there's some debate on how contagious are they as their viral levels go down, and they do. But what is safe? And it's many of us will be very mildly affected by COVID. That's another thing. There's huge range, but there's a subset in every age group that can be very seriously, could die of COVID. Right. And we don't know who they are. And I think that's the DNA genetics that we use.
So this is going to change your life forever.
I think
I don't think you're not going to be able to, but professionally and whatnot, you're not going to be able to walk away from this service that you're providing. I mean, like you said, you thought it was sort of a volunteer thing, help get us over the hump, go back to doing, the normal genetic research that you're doing.
Yeah.
And so this is going to be part of your ongoing and perhaps even an expanding part of your business.
I think that's true. And you know what's interesting is that I think it really ties in so closely with what we're doing that I'd love to kind of explain that parallel. So it's not a complete leap as much as it seems. So, you know, a lot of what we were doing was looking at genetics, differences between people that predicted different responses to stress. So stresses are certainly any type of cancer therapy, but an infection is clearly a stress, and people's bodies, their immune system, their wiring responds differently.
So let's set that up a little bit, because you and I got to know each other better because you've been developing tests at your company and at UCLA that can predict who's going to get excess side effects from radiation, for example. Side effects being gastrointestinal toxicity, sexual toxicity, these sorts of things. And so you're calling that a type of stress from the radiation. And this is similar to what you're seeing, stress from the virus. And there's parallels in the work that you're doing.
Yes, thank you for setting that up. So what we found, we study we apply a new understanding of DNA. Just differences that we all walk around with that we don't realize until it's called out. So we're stressed in some way. Infections are stress. A cancer treatment certainly is stress. We have life stresses too. And if you're different, say you and I have some difference in our stress response, and that includes your immune system, your DNA repair system. We're all designed to protect ourselves from life. But our baseline wiring is a little bit different, so our stress response is different. And what we found for radiation, and we've done a lot in immune therapy too, is that people have really different immune systems. And it's not surprising, right? I might get a cold, you don't get the cold. Yeah. So day to day, we
never knew why.
No, right. We don't know until you're tested that your immune system's different. It turns out that when we stress you, like treating you with radiation, some of the side effects you end up having are due to those differences in your immune system, because your immune system... And this is the whole
thing with COVID.
Exactly.
Some of the people are overreacting to it.
Exactly. So that's exactly like we were seeing in the immune therapy. The toxicity from immune therapies for cancer are an overreaction of your immune system, which is exactly what happens for the people that die of COVID. They have a cytokine storm. So they're incredibly aligned.
Wow.
It's incredible.
So that, and does this have to do with the the gene, the KRAS gene that you discovered directly or indirectly, or?
Great question. So we think that class of markers like KRAS, and KRAS actually predicts a low inflammatory response. So they didn't have toxicity to the immune therapies, or they have some short-term toxicity to radiation. I think they will be less likely to have bad COVID side effects, but we did find markers that predicted a very high toxicity to radiation immune therapy, and I think that same group of people will have a lot of serious side effects from COVID.
So you could say it's sort of something to the effect that if you have a really sensitive, reactive, strong immune system, that can actually work against you.
Exactly. And exactly.
In fact, I remember you once said that this KRAS mutation that you've worked in developing and discovering and implementing was possibly so common because of the issues related to the bubonic plague back in the 1600s, that was also a type of an illness that incited a gross overreaction of the immune system. And the people that had this KRAS mutation had a more tranquil response to their immune system, and they were able to survive the bubonic plague.
That has always been my hypothesis, actually.
Yeah.
That it was something along those lines.
Yeah, and I think something like a third of the population died during those. So that you'd see why that mutation would be common, because it would be protective.
Exactly, right.
Yeah.
So we've all been shaped, right? So there'll be people that are never affected by COVID, but even if it's 1%, because maybe it's been selected against, it really covers all age groups of people that will be, and we have no idea. Just like we have no idea who will have toxicity to radiation. Everybody looks the same, and we do not know till we stress you or infect you.
But you are doing some preliminary work on that. Maybe we could go into that.
Sure.
Trying to detect. What we're talking about here is that about, I don't know what it is, 4% of people have a florid reaction to radiation and have a lot worse side effects. Modern radiation has become so sophisticated and so well targeted that 95+% of people will breeze through it. They won't get the secondary urinary and the GI side effects. But then there's that strange patient out of the blue. Everything's done properly. It's not a mistake of the radiation therapist, but they have a big problem. And you have identified some ways that you might be able to pick those people out of the crowd before the radiation started.
Exactly. So applying the same type of genetics that we discussed, we can pick up. We've identified these baseline differences between people. So we had a fairly large group of 100 men that got treatment with one form of radiation for prostate cancer, which is an accelerated treatment, 5 days. Great, sounds wonderful. Everyone signs up for that. Versus about 100 men that got treated with 8 weeks.
The more traditional way.
The more traditional route. And what's interesting, radiation's become very high-tech, as you mentioned. It has allowed us to speed up treatment in 5 days, something that would normally take 8 weeks. And the truth is, about 10% of people in both groups, 5 days or 8 weeks, have some bothersome side effects. The serious ones are less than that, 3 to 4%.
Right.
So it's about the same. But we've really never known, is it the same people? Are there just people that will be sensitive no matter what we do? And who are they? So we did a study. We applied our new understanding of genetics. And actually, we were able to very, very clearly predict who would have toxicity to 5 days, about a 10-fold increased risk, up to 90% risk of toxicity.
Wow.
For 5 days, and we could do the same with the group getting treatment for 8 weeks. What's really interesting is that they're different people. So the genetics predicting toxicity to 5 days are not the same as those predicting toxicity.
So what that says then, of course, is that 8 weeks of radiation is like a different kind of treatment than
Absolutely.
a 5-day type of treatment, even though it's both radiation.
Exactly.
Interesting.
And it makes sense from the radiation standpoint. Because they're different stresses. So a big dose of radiation, your stress response is different than kind of what we do more gently with the 8 weeks of radiation.
I know there has been discussions when they decided to try and get down to like 5 treatments. There were naysayers and promoters saying that that's going to kill the cancer better, and that's not going to, because it has a different physics to it. It is distinct. But the fact that you can predict either one is fabulous. So you could say that might even open the door for patients who wouldn't be eligible to do the 5-day, but they could safely do the 8-week one.
Exactly. We actually are opening a prospective trial at UCLA for just that. So people that are coming for 5 days, which is almost everybody because everyone would rather have 5 days, that we will test their DNA before and share the information with them and say, this is your risk category if you go this route, and then it's up to them. We will not force them or randomize them. If they still want to go 5 days, they can.
Right.
But then we have alternatives. We have a 4-week option, actually, which is still gentler and we think will be the same as the 8-week option.
Right.
And there are a few other options up our sleeves. But so this will be the final validation of that. But it was very predictive and very convincing, the signature. And that's
So when we're talking about the side effects, we're talking primarily about the common things were increased urinary symptoms or perhaps irritation of the GI tract. Are those the two main things? Now with the new space-or technology, are we even seeing GI problems anymore?
Yeah, so that trial and the final analysis is primarily on urinary toxicity because there's so little GI toxicity, which is terrific. And that's become much more standard. So it's really the urinary toxicity, which you can't avoid.
Right. Because the urethra goes right through ground zero there.
Exactly. So there's no avoiding.
The other big question, of course, is any progress in trying to predict who is going to develop erectile dysfunction. I mean, that's the real
We have some very exciting preliminary data on that. Our goal in this trial is to further validate that. It's always a little challenging because we need to there's complications if people obviously were on the anti-hormone drugs. I forget what you call them.
And trying to get to it's always a challenge figuring out who's telling the truth. Not that people want to be dishonest, but it's a hard thing to measure.
Right. So we're trying to apply kind of the best tools to measure that, the best questionnaires and things to really convincingly answer that. Although we did have some significant findings from our first cohort where they did try to answer that. We want to validate that before we don't have a trial looking at that at this point, but that will be included in this follow-up study because, of course, it's important.
That's great. So let me just digress a little bit. You've been working so hard with this COVID thing, but you also see patients, and not just prostate cancer patients, but you're a professor at UCLA or assistant professor at UCLA, and you are taking care of people with breast cancer, prostate cancer, and so that is, how many clinic days a week? I know you do a lot of research as well.
I do. So I'm really just primarily breast cancer. I'm a professor and head of the research division there as well. So I have a lab, an R01 funded lab, where we do a lot of this. We recently were funded to do a lot of this research on the markers predicting toxicity of immune therapy, which are the same as we find.
So it's very synergistic with your professional, your company as well. So are any of these things going to be applicable for the breast cancer patients? So I know they get sometimes skin changes or other factors. Do you have any toxicity studies for them?
We do. Interestingly, I should mention that our markers, there's both two types of toxicity. Regardless of your radiation, there's short-term toxicity that you have during treatment and for a couple weeks afterwards, and then there's long-term toxicity. We feel, short-term toxicity is difficult, but we can always get people through it. For breast cancer with different lotions, some medications. For prostate cancer, urinary, short-term toxicity. Short-term toxicity does not predict long-term toxicity. They're often almost always different people. I think it's just a different pathway.
And is that also true for the prostate cancer patients?
Yes.
There's a separate... Yeah.
It's definitely different, separate signature. And actually, the trial really focuses on long-term toxicity because that's
what we care about.
Yeah, it's quality of life.
Yeah. Something that doesn't go away.
Right. Yeah. It kind of picks up around, it continues to increase actually even after a year. Yeah. So we try to predict those. So breast cancer, we have all the DNA from all these women. Toxicity is pretty rare in breast, actually. We see short-term toxicity, and there's variability, and we do have biomarkers, but would we change management for that? Because we can warn people. We always warn people. You may have skin peeling and such, and if we just apply the creams and things.
Something's definitely changed because when I got into this 30 years ago, the cosmetic effects of radiation on breast cancer were dreadful, and I think a lot of that's been corrected now. I have to say, so there are still people that have very dramatically disfiguring responses to radiation. Fortunately, it's very rare, but I'd say 1% to 3% of women
dramatic changes. And so part of my challenge has actually just been getting enough of the people with the bad side effects, which is great, except it would be good to know who they are.
Right.
Many of them, they're older women. It can be bothersome, but they don't care enormously. But it's really problematic if it's someone that has a reconstruction, because they could lose an implant. It really becomes a significant issue. So it's important to identify that group. So we do have those studies ongoing. It's a matter of more just collating all the data.
Finding enough people that had a problem so you can get their genetics tested.
Exactly.
So we know a lot of the, if not maybe all the cancers are caused by some sort of an underlying mutation. And we've had genetic testing, DNA testing now for several decades. But we've failed to really identify a lot of these underlying mutations that are presumed to be there. We found some. We know that some mutations cause cancers, and we're able to make that connection. Sometimes that leads to an effective therapy. That oftentimes is a stepping stone to designing an effective therapy. But for a lot of the cancers, despite all this energy and money and research, it seems, my impression is that there's still a lot left to be done. Do you have any sense of what's been holding that back?
I do. I mean, I think what we needed to have happen, which did happen about 20 years ago, was to fully understand our DNA. From the beginning, from the 50s, we only understood 2% of our DNA, which is the part that makes proteins. And that's where all the research is focused.
So that's like the structural stuff.
Yeah, so it's BRCA or P10. Anything you know a name of from the DNA is a protein.
Right.
And the few mutations we have are in proteins, so they disrupt one of those. But we thought 98% of our DNA did nothing. So around 2000, 2001, when they sequenced the genome, they said, we just have a bunch of junk. We have this huge piece of DNA.
They literally called it junk DNA.
Yeah, they said, there's just, we're just a waste.
Does
we're
that
like
give you confidence in the scientific research that something as complex as the human being would be carrying mostly junk in their DNA?
Yeah, of course it
But
does.
everyone believed that.
I know.
It was universal.
Amazes me, right. So I have to say what has always amazed me in science is that it never, there's nothing silly, really. We just don't understand it. Yeah. So when we understand it, it's actually so complex and beautiful, actually. Wow. It's just incredible. Really gives you,
So what you're saying is we were kind of looking in the wrong place? Is that what?
We were looking in the wrong place. We didn't know what the rest of the DNA could do, and then they came out with technology to try to look at the rest of the DNA, which had its own just flaws that wouldn't pick up functional markers. And it really took until the discovery of these, they're called non-coding RNAs, which actually are functional and take up about 80% of our DNA, makes these non-coding RNAs. Wow. And they are the masters of the cell. They're the masters of everything. The proteins are tools, and the non-coding RNAs are the construction,
so they're the regulatory component.
Yeah, they manage everything. And they tell 500 proteins
and the reason we missed it is these are just little tiny bits floating in the blood, going around. They're like talking, sending messages.
Yes.
And we didn't really have the technology to detect that.
We just didn't think it mattered. We didn't, right.
We thought it was just bits and pieces floating around.
Right. And everything we did kind of washed away the little pieces. And it really took, actually, Frank Slack, who's the co-founder of MiraDx, as his
which is the company.
Which is our company.
Yeah.
He discovered the first human microRNA. They were found in C. elegans, these little worms. And what they did was in C. elegans, to discover, different genetic, it's a developmental model, so they would cause damage in parts of the DNA. And this one spot caused dramatic differences, and it wasn't a protein. And they couldn't figure it out, and they finally realized that's where the first microRNA was discovered. There was one discovered in 1994, but that wasn't found in humans. And then Frank, during his postdoc, he found LET7, which was the first human microRNA, conserved across all species. And this tiny, tiny little piece of, DNA, RNA, is so powerful and regulates everything, small but mighty.
So in theory then, you could in the lab make these things and inject them into people and possibly create differences in the organism.
Yes, so there's been a lot of work trying to actually deliver microRNAs as therapeutics, as therapy. It seems that they're maybe too powerful. So people have huge systemic inflammatory responses. Wow. Yeah, they're actually too strong to do such things. But our genetics looks at, that's exactly what we look at, differences in those powerful elements. So if you're born with a different spot in your DNA for making that or responding to those really powerhouses, you're going to respond differently to life and stress. And that's what all of our work's based on, actually, that new understanding of DNA.
Well, this is what we learned back in basic biology, this concept of what we call homeostasis, the idea of the thermostat that, the heater goes on when it goes a little too high, the heater goes off when it goes a little too low, and you put a microRNA in the system, and all of a sudden you've just turned it up to 120.
Oh yeah, very powerful.
And the heater works. There's a powerful thing, but it's kept in balance and in check in your body in normal life. And so to learn how to modulate that will be the real art then. Yeah. So you're working in your company. Why don't you tell just a little bit about MiraDx to develop and commercialize? And of course, I think it's been primarily for diagnostic purposes. So if you can detect that there's a low level of one of these microRNAs or a high level, that can give you information about how someone may respond to radiation.
Sure. So much of what we've done is really validate and educate the world about microRNAs and how these differences in microRNAs can predict such different responses. I mean, because everyone had so heavily invested into the protein parts of the DNA, it took a lot of work. It's taken years just for people to kind of catch up.
So people are saying, nah, this is just,
I got it
this
covered.
This is a fanciful idea. This is ridiculous. And in other words, you're saying it was actually hard to convince to make it sound plausible, is what you're saying.
It's almost too simple. There's so much technology applied. They sequence the entire genome, and there's been a lot of focus on being able to do that. But we can pick up these genetic differences from a really simple test and give more information about a person's response or toxicity or side effects than all that data. And I think that was a little hard to swallow.
Well, the thing is, so are you focusing on certain leveraged microRNAs that you've already discovered, or are you in the process of putting out a broad net to try and find more microRNAs, or both? Or
our markers are really looking at where the microRNAs sit on the DNA to direct things. So it's baseline differences in DNA. And we discovered the first example in cancer.
So that's where the mutation is.
Exactly. The
where the
mutations,
microRNA comes and talks to the DNA.
Exactly. To its key target. In KRAS, LET7, its key target is KRAS. And we found a mutation where LET7 needs to communicate. And people with it just communicate a little bit differently. And in times of emergency stress, if you do it differently, you just go down a completely different pathway in your stress response. So back in 2009, after we discovered the KRAS variant in 2006, we did a very detailed analysis. At the time, it was very hard because the technology wasn't quite there. Throughout the genome of all known microRNAs, where they bind, their binding sites, to look for genetic differences in those regions. And we found a huge library of about 10,000 of them. And then over the last 3 to 5 years...
Are you able to tell which are the functional and non-functional mutations?
That's a great question. So it's funny, we don't know what path they'll take you down. We just see that there is a variation in that site.
Yeah.
And it's a really important microRNA, and it's a really important target. And if we stress you, you're doing something different. And it depends on the situation. So even for KRAS, if it's not overreacting to coronavirus, that's a good thing, right? But, you might be at higher cancer risk, and you might have short-term toxicity from radiation. There's some bad things. So it just depends, right? Nothing's all bad or all good. It's a situational thing.
Right. So have you looked at the patients that have done poorly with the coronavirus to see if the KRAS is protecting them at all?
So we're beginning to look at that. Most of our patients, which we've tested over 100,000 people at this point for coronavirus, which is just so crazy. But they're outpatients, so we haven't actually yet had access to hospitalized patients. And we don't have long-term follow-up, so we don't know. We will be able to look at, symptoms versus no symptoms, because we have good details on that. Duration of illness, because some people carry it for a really long time, others are done in a week. I think our genetic markers will be able to, tell us information. We definitely look forward to applying them to those groups. At this point, as I mentioned, though, we don't have access to those with the most serious side
Right.
effects will be important. Because then one thinks, the goal would be to be able to identify people ahead. You are someone, if you get infected, that will really be sick.
Right.
And you need to protect yourself at all costs, limit your exposure. But 99% of people, that's not the case.
Yeah.
So
Yeah, that's identifying those people, the outliers that are really at risk. Is there anything in this genetic area or in any area of genetics that you're aware of that has anything to do with mental performance, human intelligence, and I know that we all know that smart people run in families and that there are genetic components to that sort of thing. Are you familiar? Well, the reason it interested me is I can't imagine that some of the large totalitarian regimes out there, which probably don't have the same ethical foundation that our Western culture does, is working on stuff like this. Do you see that is there anything out there that do you think that's going on that can identify these things and then somehow nurture them in that direction?
That's interesting. I'm sure that there will be baseline differences in these regions, which are master controllers, these microRNAs, that predict different human biology, no question. From, genetic, just features as well as intelligence and all those, and stress under, ability to manage different types of stress, certainly.
Yeah. Well, you certainly see that in performance that we always have that respect for, people in the professional world in athletics and whatnot. Somehow they're able to remain that tranquil under tremendous stress.
Right.
And
so I'm sure that's their genetic underpinnings, and I would imagine that since it's a stress and you're responding differently, that these microRNAs are part of that, certainly.
Mm-hmm. So have you become an expert in stress through all the years research? And it's to me, the stress, I get that asked that question by patients a lot. Do I need to reduce stress in my life, Dr. Scholz? And my answer is you need to reduce constant, unremitting stress.
Mm-hmm.
But that periodic stress, in my opinion, makes you stronger. So that you're exercising. There's even some evidence, I think, that people that are exposed intermittently to some degree of radiation actually have, because it awakens the radiation repair mechanisms in your body. But it's like getting a cold, say, every few years, that your immune system has to do its thing rather than just laying dormant year after year after year. And that there's this idea of intermittent stress may be good. Of course, what was it that was it Nietzsche that said that if it doesn't kill me, that I'll be stronger? Yeah,
I've been saying that a lot lately.
Yeah, have you? What is it that are you finding a little private and quiet time for you? You've been, I know, working hard to develop all these new COVID tests. Are you able to get away from work at all? And
it's been hard. I mean, I have had family, so that's always, we try to have dinner every night. I try to get home for that. Spend a morning to go hiking with the family has been really enjoyable. What I don't like doing is still talking about COVID all the time at home. My husband's gotten really involved in helping with the company, but I'm like, I really don't want to talk about it right now.
I know that
Please,
feeling.
I don't want to talk about it.
Yeah.
I bet. So yeah, it's been. After a couple months into it, I realized this. At first, I thought it was a sprint. Then I'm like, all right, it looks like a half marathon. All right, we're into like an Ironman, and I'm not in shape for this. So I realized I really had to strike some balance, that this was a long haul. So we've been trying to build up support of the company and train people and keep some balance and perspective. And we're doing our best, and we're doing it to do good. And so I'm appreciative, actually. I feel like I've been given the opportunity to help. It's much better than sitting home idle, I think.
Yeah.
So I try to remember that and just I'm thankful, actually.
Yeah.
As tired as I am.
Yeah. Well, I mean, you've always seemed to have been very positioned in purposeful pursuits, and you've been involved in a lot of different research along the way, and then you do have a nonprofit foundation, I think, that maybe you can just mention briefly what that.
Sure.
Yeah.
So MiraKind, I spun out from MiraDx in 2013 when after a year of business school, and I really better understood that for women's health and cancer prevention, that was a better place for it. And what we do is we try to engage people in studies where they send in genetic samples to partner with them to answer some of the most pressing questions that they have and find answers with them. And I love doing that, and I have a really faithful following there. It's wonderful.
So this is designed to help people that maybe have had cancer in the family and to get to the root of what it is? Is this what we're just, the diagnostic side of it, or what?
Yeah, so we have that nonprofit is really built around our first marker, which is KRAS, this mutation in KRAS, where we really have found that it's a much higher risk for women to develop cancer if they have it than for men. We found a lot of that appears to be due to estrogen withdrawal, and that actually maintaining estrogen is protective. So we've worked with some really great groups. When we found that, the timing was what I would say an important lesson I've learned is how important timing is in sharing knowledge, because sometimes people are just not ready to hear it. When we first discovered these markers, everyone had just invested heavily into tumor sequencing, the whole world, and they just did not want it. They said, we'll find all the answers. Right,
because we'll know the DNA sequence. It'll all be there before us, and it'll all talk to us.
Yeah,
and that was a giant overestimation.
Right, unfortunately. Yeah. And then, we found that, about 2015, that it seemed that maintaining estrogen for women with the KRAS variant was protective against cancer, which really was at the tail end of studies suggesting that no one should have hormone replacement therapy. Our findings suggested that women with KRAS variant should continue hormone replacement therapy. So that's kind of come around. At the time, it took us a year to publish the paper because people didn't want to hear it. But now we have a lot of great partners who are that's been embraced now, that it's true, that it's really okay for a lot of women.
I think one last thing, we've been talking about KRAS, that it's in a microRNA, that this is a regulatory component of DNA, and it's these regulatory components have a lot of leverage and they're very powerful. But I don't know that we've really just given a simple description of the KRAS mutation itself, and maybe you could just talk just a little bit about some of the implications you mentioned that in women well, anyway, I'll let you kind of elaborate on that.
Sure. So, based on our search for this type of mutation really came from Frank's discovery that KRAS, which is an incredibly important, they call it a proto-oncogene. So part of our DNA, that it's a protein, but if it's not controlled, it can lead to cancer. And there was a handful that were discovered. Interestingly,
so the mutation, when it's present, predisposes those individuals to getting cancer.
So actually the KRAS protein itself in a tumor, if the tumor mutates KRAS, or a cell loses control of KRAS, it will develop cancer.
Okay.
That's a proto-oncogene. So we knew that that's a protein part of KRAS, and that's a common thing in tumors. It's in about 30% of human cancers, mutations in the protein part of KRAS. We knew that LET7, this first discovered microRNA, was the boss of KRAS, controlled it. It didn't work through the protein part, it worked through the regulatory region. So we looked really carefully, we sequenced that regulatory region to say, was there a miscommunication? We actually thought that maybe in a tumor, we'd find there was mutations that caused a miscommunication. But instead we found that there are just people that always have had just a little bit of a broken dial in their KRAS control center. So it's a germline inherited mutation in KRAS. We call it the KRAS variant, which is maybe not the perfect name, but trying to say it's about KRAS, which everyone knows. But it's not a KRAS mutation, not a tumor mutation. It's something you walk around with all the time. So it's a regulatory mutation. And that's the basis of all of our findings. So to test for the KRAS variant that we study, or any of our mutations, all we need is a cheek swab, because it's in every cell in your body. You're born with it. It's in your DNA. And it's very easy for us to test that. It isn't something that changes in a tumor or in a disease state.
So if people find this particular mutation or they carry it, are there any specific measures that they should adopt in terms of additional cancer screening or something like that?
We do recommend for women with it. We recommend there is some good screening. So certainly heightened breast surveillance, because their real risks are actually breast cancer and ovarian cancer. Ovarian cancer happens after menopause for them. We do think consideration of continued hormone replacement therapy is a reasonable consideration.
So that becomes protective.
Yeah, because that appears to be protective for them. It's hard. I mean, cancer initiation is a complicated thing. We know these women are at higher risk. We'd like to, our studies are trying to define the best ways to prevent that don't involve just kind of radical surgeries or, what I think are, someday we'll look back and think are barbaric approaches to prevent cancer. There's probably better ways to do it. So that's the goal of a lot of our studies.
So I think my last question has to do with, it's interesting, we see all this science going forward so quickly, and you mentioned that sometimes the world really isn't prepared for the new knowledge. It's sometimes the community thinks it has things figured out, and that new information doesn't get in. Taking all that into account, where do you think, is there any way that we can move this more quickly? Where are we going to be 20 years from now in terms of, because we do see immense progress, and eventually the industry does get it, and thank God there are financial incentives for the pharmaceutical companies to pick these things up and then sell it. But and I've seen, I think, more discoveries in the last 5 years than I saw in my whole career. But are you optimistic about this? Do you think that we're going to see some big breakthroughs in the next 10, 20 years?
I think we're beginning to see them, and I think we will always be slowed down a bit by what is honestly just academic jealousy and competitiveness, where a lot of the groundbreaking discoveries happen in those settings with really smart scientists who partner with people with clinical knowledge. But that's fraught with complications and challenges, I have to say. But I think with our new understanding of DNA and the immune system, even with these immune therapies, there's going to be a lot of progress. There's just a lot of stakeholders, and it's tricky to navigate. But if you're determined enough, you get there.
You get the job done.
You get there eventually.
Well, I was sorry to drag you away from, I know you've been so busy fighting this COVID craziness, and it's so kind of you to come out. And
Oh, it was great.
Just great to see you.
It was great seeing you too.
Yeah.